Okay, I see a couple of people are still coming in, but let's go ahead and get started. We have a very full hour, but we are extremely excited about all of the folks joining us today. We have representatives from both the Department of Veterans Affairs, as well as your fellow We Honor Veterans partners and community providers. So a few quick things right off the bat. Yes, this is being recorded. Yes, we will be sharing the slides. Joining me today, and I'm sorry, my name is Catherine Kemp. I'm the Senior Director of Veteran Services at the National Hospice and Palliative Care Organization. I'm very happy to be joined by my colleague, Marge, who many of you know and love. We will be on the chat box, as well as the newest addition to the We Honor Veterans family, Abby Sauer. She is here joining us as an intern for the summer, so very happy to have her as well. But this will all be posted. We know Em is super speedy. It will likely be up on the website by the end of tomorrow, if not Monday at the very latest. So do not worry, everything again is being recorded and the slides will be shared with you. So we're going to go through a couple of presentations today. Then following those, I'm going to walk everyone quickly through the newest resources that we've posted that have been pulled and very generously given to us from participants of the Building Community Connections Initiative. So make sure that you all have access to those as well. Okay, to kick things off, I'm very excited to be introducing Andrea Leonards. So she has been working at the Greater Los Angeles VA Medical Center as a palliative care nurse for over 10 years. Also extremely relevant is that she is an LNEC for Veterans Programs trainer, which is incredibly fortuitous, as we are happy to announce as of next week, the newest updated LNEC for Veterans curriculum will be posted on the We Honor Veterans website. So more information on that to come. But yes, without further ado, very happy to turn it over to Andrea.
Thank you, Catherine, and that's very exciting news. All right, let's see if I can get this started. Okay, can you see my slides okay?
Yep, you're good.
Thank you. As Catherine mentioned, my name is Andrea, and I'm speaking on behalf of our palliative care chief here at Greater Los Angeles, Dr. Deborah Moran, who is not able to be here today. And then at the end of this presentation, I'll introduce our hospice community partners who have joined us today as well. So the Building Community Connections team is comprised of myself, our health psychologist, Dr. Megan Taylor Ford, and as I mentioned, our palliative division chief, Dr. Moran. I'll briefly describe and define what palliative and hospice are, and mostly I'll just be talking about the Building Community Connections Initiative and how this has generated a lot of discussion among our regional VA hospice and palliative care teams. In VA speak, we call this Vision 22. As many of you know, hospice and palliative care is for those with serious life-limiting illnesses. Hospice is the most intense part of palliative care for those with a prognosis of 6 months or less. And for those who desire typically comfort-focused approach to their care at the end of life. Hospice is a benefit to all veterans, regardless of service connection or income. And hospice is a philosophy of care that can be delivered across various settings, such as skilled nursing homes, hospitals, or most commonly at home. In 2010, the National Hospice and Palliative Care Organization, in collaboration with the VA, launched the We Honor Veterans program campaign to provide education and support to hospice agencies, acknowledging the unique aspects of care for our veterans at end of life. So just getting into a little background about the Building Communities Connection, we know that the vast majority of veterans die outside of VA facilities, and that's usually at home with the community hospice agencies caring for our veterans. So in 2019, there was a congressional mandate to improve the care of veterans impacted by trauma for those on hospice. And the aim was to build and strengthen partnerships with community hospice agencies to provide better care for our veterans. The Building Community Connections Initiative was rolled out in 2 parts, and this goes back to 2019 is when the first one was rolled out, not too long after the start of COVID. So there were select VA studies nationwide that were chosen to participate in this, including the Greater Los Angeles VA. We were tasked with developing and disseminating information to hospice agencies about the kind of support that the VA can offer, focusing on the unique aspects of veterans care, specifically PTSD, moral injury, and suicide. The implementation of this training looked very different across different VAs. Here at Greater Los Angeles VA, sorry for the phone call. Here at Greater Los Angeles, we had a half-day in-person training where we invited community hospice partners to come and hear information about PTSD, moral injury, and suicide. Nationwide, this resulted in the education of more than 1,000 community hospice staff. So this leads us to the second part of the Building Communities Connection, and this was rolled out in early 2022. And the focus of this part of the initiative was specifically on access and provision of VA services, specifically using VA telemental health services. So that means communicating or reaching our veterans through a video visit, whether it's by phone, iPad, or even by telephone if some of those video options were not available. Another aim was to provide ongoing information to our community hospice partners about caregiving and respite services that the VA might be able to help with, as well as continued education about like VA's open access model. So veterans at home with hospice can continue to come back to the VA to receive care and see their providers, including palliative chemotherapy, palliative radiation, which is very different than caring for civilians. And again, just more of the consultative support that the VA can offer, such as homemaker program or the caregiver support program. Just some examples that we'll talk about later. So let's look at how Greater Los Angeles implemented the second part of this Building Connections initiative. So really it was something simple. And again, it was just us 3 people, Dr. Moran, Dr. Taylor Ford, and myself. And in order to identify those veterans at home on hospice with a past history of trauma, we just did a quick chart review of all the home hospice referrals that came through. And then we would contact that individual hospice agency and let them know, hey, there's this veteran who's coming on to your services, just so you know they have a past history of PTSD or moral injury or whatever have you. And then letting them know that if it seems like there is some specialized telemental health care that we can help with, please contact us. So then the hospice agency would contact our palliative care team directly if that veteran agreed to VA telemental health services. We would put in a psychology consult, and then our health psychologist would meet with that veteran either via a video or telephone visit and provide ongoing specialized telemental health services. Another aim of this Building Community Connections initiative was an increased awareness of VA resources and services among hospice community partners. So this was included information that we sent to our hospice agencies about some caregiver respite support, burial survivor benefits, enrollment in VA, and most recently about the caregiver support program. And again, as Catherine mentioned, these resources will be available in the chat if they haven't already been posted. So the outcomes of this implementation resulted in increased utilization of VA telemental health for veterans receiving home hospice. Another outcome was an expansion of VA non-telemental health care for veterans on home hospice. So an example of the non-telemental health care encounters would be when hospice agencies would call our team with updates about our patients being cared for. So if they, for example, went to crisis care, or they went to an outside hospital, or they needed more services from the VA, those are the type of examples of the increase in non-telemental health encounters. So ultimately, this initiative resulted in improved access to VA services and benefits for veterans on home hospice who have been impacted by trauma, and how the VA care can supplement the hospice care plan with services and benefits not always provided by the hospice agency. This has generated lots of discussion, as I mentioned, among our regional VA and nationwide hospice and palliative care teams. So this process is actually, readily reproducible and actually self-sustainable just by strengthening the connections and the communication with our community hospice partners. It has really resulted in a self-sufficiency. They know the services that the VA has to offer. Now we don't need to contact the hospice agency and let them know about the past history of trauma with our veterans, because they already know to reach out to us for specialized telemental health services. So there was a 4-fold increase in access to telemental health services, and there was a 56% increase in non-telemental health encounters. And again, those are when hospice agencies contact our palliative care team directly for questions or support. Another aspect of this initiative was providing bereavement resources. And this is especially important when completing the death certificates. The hospice medical directors know to take special consideration to veteran service connected conditions, which we know can greatly impact the survivor benefits. And today I am happy to present, to introduce some of our hospice partners who have agreed to come on and talk about the collaboration that we've had. They're very skilled and experienced hospice partners. The first person I'll introduce is Alicia Meyer. She's a social worker with Rose Room Hospice, and she'll talk about a little bit of how we both communicate or collaborate.
Thank you, Andrea. And I really cannot stress enough how valuable it is to have a designated person to collaborate with on the VA palliative care team. Let alone one that is as responsive and available as Andrea. I mean, she answers her phone and gets back to you really quickly, and I really appreciate that, Andrea. I really, really do. And I also know it's reassuring to my patients who are veterans when I tell them I have a contact at the VA that I can call and consult about their VA benefits. Our veterans and their families often aren't aware of the benefits available to them from the VA at end of life. And it can get a bit confusing. It still confuses me sometimes of service connected, not service connected. Are they even enrolled to receive VA healthcare benefits? So I really appreciate having this connection to Andrea, because it's important that the hospice staff serving our veterans understand the VA services available to them. So as far as VA telemental health, for many people at end of life, it is a time to reflect back on their lives and take stock. This can be a difficult time for our veterans if there are emotional and psychological issues that they're dealing with as a result of their service. So it's important for us to assess what's going on for them, and if they would like to participate with mental health support from the VA, who specializes in their unique trauma that they've experienced. I have been able to work with Andrea to get a referral for a patient to receive telemental health calls, and it's a great benefit to them. And just because they're at end of life doesn't mean they don't need the support still. So, and on my end, I do my best to help the veteran and patient follow through with the referrals. I have, in this case, actually been present to help support them to make the initial call to the VA therapist that to start that process to support them. So it's been good. As far as the VA homemaker program and placement, caregiving and getting support with caregiving is a big challenge for many hospice patients, not just veterans. And oftentimes the family is tethered to the home because they're not able to leave their loved one alone. Or if a veteran is living alone, it is helpful to have some assistance with personal care, fixing meals, or getting to appointments. And too often the funds just aren't there to hire a caregiver to help. So the VA homemaker program has been extremely helpful to our patients and families to fill the gaps in the care needed at home. For those not familiar with this program, with the VA homemaker program, it can cover up to 4 hours a day, up to 7 days a week of caregiving. And I have referred many of our veterans who are patients to this program. I do my best to give them realistic expectations that even though it says up to 7 days a week, it's likely to be approved for more like 2 to 3 days a week, which may not sound like a lot, but where we are in California, it can cost $35 and more an hour for a caregiver through a caregiving agency. So having even 12 hours a week covered by the VA is a great support. Now, if they need more support than the homemaker program can provide, or maybe the caregiver needs respite or to take a break or go on vacation, a huge benefit the VA offers is to cover placement in a community nursing home. And as long as the patient qualifies for hospice, the VA will cover the cost of a nursing facility. And in our area, it is running $10,000 a month. So this is a huge benefit. And I have worked with Angie on, again, numerous occasions to get veterans in a VA contracted facility. You know, we have one right now, married 70 years. The wife is unable to manage his care at home, and the family, the 2 children, were trading off month by month on staying with them to help provide the care, and it just wasn't sustainable. So this ability to work with the VA to get this family assistance is a huge thing. And there's also placing a veteran in the VA hospice facility, HUGs, is also an option if there's space in their facility, if that's what the family prefers. So it's been really great over the years working with Andrea to really understand what VA benefits are available to our hospice patients and work with them. You know, and Andrea's also been, it's not on the slide, but she's been very supportive and just a resource to consult with how to get through the application process to apply for VA healthcare programs, and what do we need to put on these documents to make sure that the spouse is able to receive the survivor benefit. So again, it's been a very beneficial program to work with the VA and specifically with Andrea. So thank you very much.
Thank you, Alicia. And now we'll hear from Ruben. He is a physician's assistant with Bonham Hospice. Let me see if he's still here. Ruben, are you there? Ruben, if you're able to connect, that's great. Otherwise, I'll just kind of cover some points on how your team collaborates with the VA. We do warm handoffs when there's a hospice admission, especially one from the hospital. And when a veteran is discharged, if they outprognosticate, then they contact our team so that we can replace the equipment with VA equipment and start to provide medications that hospice was providing. And
Sorry,
also,
Ruben, are you able to speak now? You should be off mute.
are you there, Ruben? I'll just continue to cover a few of his points. I don't want to get too far behind with time. And the non-hospice covered medications, their team also contacts the VA about the medications that hospice doesn't provide that the VA will still provide, like insulin or cardiac medications. And then VA care coordination. If there's a veteran who's in the home who needs a paracentesis, we help, we collaborate to make sure that that veteran is able to get here and get the care that they need to promote their quality of life. So I think just because of time, thank you so much, and we'll move on to the next presentation. Thank you.
Be able to share? Okay.
Hi, this is Dr. Blakowski from the Pittsburgh VA. Thank you very much for asking us to present today. And what we wanted to do today was to present our program and how we have been working with our community agencies to care for our veterans in the community. So, as Andrea said, there are very unique challenges in taking care of our veterans and their families. And I think a lot of people really do not understand these unique challenges. And I know when I talk to our house staff here at the VA, I ask them to think back. I asked them to think back to when they were 17, 18, 19 years old and what they were doing. And many of them were still in school and they were in college and they were having a great time with our lives. But this is the time when our veterans first went into the service. And they went into the service with the idea that they were going to learn how to kill and not to be killed. They learned a lot of different strengths. And unfortunately, their time in the service also brought them a lot of problems that they were facing later in life. By the time a veteran is 20, 21, or a military person entering the service is 20, 21, they are a veteran. A person, college student at 20, 21 is still in school. But those 2-3 years in the service cause a lot of, as I said, stay with the patient, stay with this veteran for the rest of his life. We are taking care of many veterans now from the Vietnam War era. And when you think about it, at the age of 19, at the age of 20, you may be told that you are going to be the leader of a squad. A squad consisted of 6, maybe 10, 12 soldiers. The point person in the squad was the first one to go out into those marshes and to those grasses that were over your head. We know that 50% of these soldiers did not make it back. 50% of the point persons didn't make it back. But you, at the age of 19 or 20, have to make that decision on who is the point person. I've often asked people, do they think that they can make that decision? But yet our veterans did. And it's not only that which has caused problems with PTSD, caused problems with moral injury, which goes a lot deeper than PTSD. Moral injury goes right to the core of who you are. Prior to going into the service, most of us have a Judeo-Christian background where it is wrong to kill. But in the service, it's just the opposite. If you don't kill, you can get court-martialed. And then to go back outside of the service, back to the Judeo-Christian beliefs, How do you deal with that? How do you deal with the 2 years that you spent in the service where you did things that were totally against what you were brought up to believe and do? These are the things that our veterans have to deal with from their 2 years in the service for the rest of their lives. Many of the physical problems that they develop, some of the cancers, some of the cardiac issues, some of diabetes, ALS, chemical injuries, are directly related to that 2-year time in the service. How do you deal with that, knowing that 40 years later, 40 years down the road, that you are dealing with some of the injuries caused by these times in the service? In Camp Lejeune, Vietnam, Agent Orange, the burn pits. The VA recognizes these unique needs of the veterans because of that time in the service. They have developed different mental health programs. They've provided family support for veterans because of the times in their services. You have to remember that the problems of PTSD, moral injury, affect the families too, because of the fact that veterans have problems. They run away like anybody does from these issues. The high rates of alcoholism, suicide, drug abuse. The VA does provide family support. And now with the PACT Act, which is a much more proactive approach to identifying diseases that the patients may have encountered because of the time in the service. And as mentioned before, the very specialized programs, the burial benefits, et cetera, that we provide for our veterans because we want to show them that we do care. I'm not going to talk about this. This was mentioned earlier, but there's a lot of mental health issues, as I said, with veterans. But it was found that only 28% of community hospice staff feel equipped to manage the situations related to a veteran's mental health at the end of life. I have found it really interesting that many veterans will hide. They will not talk about these issues, but at the end of life, it comes out, and it comes out in a rush. And all of a sudden you come out of a patient's room and you say, oh my God, I didn't realize this, I didn't know. How do you talk to that patient? How do you help him? You're not exactly sure how to do it. We had a patient who was in Cambodia. We weren't supposed to be in Cambodia. He was told, they had a whole group of Viet Cong that they were told to have them dig a ditch, and they dug a ditch, and then they just shot them, and the Viet Cong fell into the ditch. He never talked about it. He never told his wife. But then what he told us, he said, you know, it's not that I did it, but that I enjoyed doing it, and I do it again. How do you deal with that if you're out in the community and there is nobody that you can call to deal with these issues? How do you deal with that? So luckily, Congress, as was said earlier, initiated this or address these issues, the Consolidated Appropriations Act of 2018, which tasked us to create pilot programs to identify and respond to the trauma-related mental health issues of terminally ill veterans. I like to say we need to get them earlier. How do you deal with somebody with a moral injury if they have only X amount of time to live? We want them to be identified earlier so that we can make sure that they have a better quality of life as they go through the dying process. Remember that the majority of the veterans do not go to the VA hospital. They are in the community. We need to bridge that gap to provide the resources that we are able to provide in the VA to those veterans that are in the community, to provide the resources for veterans who are using both the VA and the community. And as I said, also for those veterans that are just in the community. We need to make sure that we raise awareness of the benefits, as was mentioned earlier, the different benefits these veterans have. It's amazing. It is just truly amazing that what the VA will offer to take care of these patients as they get closer to the end of life. The care, the amount of care that's provided for our ALS veterans, it's just kind of blows my mind. And one of the things that we have here at the Pittsburgh VA is really been focusing on is the VA Palliative Telemental Health Services to help fill that gap for our trauma-related mental health issues. So what did we do? What did we do in our efforts to try to bridge this gap? Well, there are three things that we did. First of all, we partnered with our community agencies. It's important for us to develop some type of relationship with our community agencies. We provided support by providing education. And then what we did is we expanded the process for our telemental health care. As far as developing stakeholders, our palliative care coordinator, Deb Gorel, did a great job, a wonderful job of reaching out to different community partners. This is through the Pittsburgh Veteran Community Partnership, through the Pennsylvania Hospice and Palliative Care Network, the PA Development of Military and Veterans Affairs, et cetera, et cetera. We did this in an effort to find out what they know, how we can help, what they can do, let them know what we can do. We developed a partnership, a communication, so there was some give and take, and we're able to work with them so that we can, again, focus on providing the best quality of care for these men and women who have done so much for us. We then provided a lot of statewide education. We provided education to the different hospice agencies. We provided education to the different partners about PTSD. What is PTSD? Moral injury, suicide. How do you address these with these patients? Where could you get the resources? We had our chaplains talk to the different agencies. We had people from behavioral health to give them some ideas of what to look for, because many people do not know what to look for. Here in the VA hospital, we know what to look for. We know what questions to ask. We know when to keep on prodding. We know when to stop. But how do you know it in the community if you don't deal with these patients on a regular basis? We provided education about caregiver support. We provided education about the state Veterans Home Program, enrollment for VA benefits, burial benefits, survival benefits, etc. All these things were mentioned earlier, but there's, again, a tremendous amount of support and benefits that can be provided not only to the patient, but also to the families. When we developed our telemental health program, we looked at how can we make sure that we specifically develop, or we looked at those patients who had specific problems because of trauma. And that had to do with their time in the service. It's not only due to the time, as I said, in Vietnam. These are the patients that we're seeing now, but we also have patients that we're seeing from Iran, from Afghanistan, those multiple deployments that they had. So we went and we developed some guidelines where we said, okay, if you have a patient that you feel needs some help, what are the guidelines to make sure that they get the kind of help they need? And then we expanded our capacity. We developed the guidelines, we developed the partnership, we developed the education, we gave them information on how to refer, and then we said, we have now a palliative care mental health that we have developed with behavioral health providers who are skilled in dealing with these issues. We welcome any consult that comes in, which is then screened to make sure that they are appropriate. I always say, send the consult. You know, you'd be surprised. They may not be appropriate for that type of resource, but yet there may be appropriate for other resources that they might need. We are very, very lucky in our VISLM that we have several mental health providers that have a great interest in taking care of patients with palliative care and hospice needs. They have developed different resources, different brochures. They have been very, very supportive of this process. So we've been, as I said, extremely, extremely lucky. So bridging this gap, there's a big gap still, and I'm going to let Marla Kaplan talk a little bit about the gap or what she sees on the other side. We provided the education, the support, etc. But yet, how do we make sure we bridge that gap? What are we missing? Because we don't know what we're missing on the other side. So I'm going to ask Marla Kaplan from one of our community agencies to talk to you a little bit now about what she sees the issues are.
Hello. Thank you, Dr. Bukowski and Deb. It's such a pleasure to be here. I'm Marla Kaplan. I am a licensed social worker. I'm a certified healthcare ethicist, and I work with Gallagher Home Health and Gallagher Hospice. I've been out in the field for 30 years, but with Gallagher now for the past 8 years. And when I started with Gallagher is when I started with the community partnership here and have really gotten to know this team extremely well, and am just incredibly grateful for the partnerships and the contacts, because we do have gaps, but it's made life a whole lot easier. So I'm sorry, give me 1 second here. So, you know, we have a duty and a responsibility as providers, as healthcare professionals, and it's our collective responsibility, you know, to not only to care for our patients, but to really ensure that we connect them to all resources and all care that can be helpful for him or her, as well as for their family and loved ones. I think about palliative and hospice, right? It's patient and family as a unit. You know, I go back to, we're human beings. We are not a diagnosis. We're not a medical record number. And when we look at somebody, we shouldn't be looking at them in that way, but we should be looking at them from all facets of life that they do. So I also like to always remind my colleagues and, you know, the patients, you know, we never want to forget our touchstone. You know, why did we go into healthcare, and why do I do, or why do you do what you do every day? So we need to strive to do our best. And we do that by knowing what's out there. And we do that, of course, with our best practices, right? So we know what we know. We know what we don't know. But we don't know what we don't know. And this really is where our journey begins here. So it's until we ask and until we listen, because we can't do any more if we're not asking the right questions and listening to what we're being advised. So what do we know? Well, we know the Department of Veterans Affairs runs programs that veterans, you know, to support the veterans and their families. They have a ton of resources. And as Dr. Bukowski just mentioned, I mean, the things that they can offer and the things that they can do are just overwhelming. It's incredible. But what we don't know, you know, you go through these things of how do we access it? What resources are out there? Where do I start? You know, what is my patient eligible for? What will he or she qualify for? How much time is this process going to take? I know you guys are all relating to this, like head in the hands, like where do we go? Where do we start with this massive system, right? So with that, though, of course, you know, as a provider, you know, we struggle. We struggle with a lot of this. There are definitely some gaps. You know, some of the things that I can just talk, you know, off the cuff for a second is I mentioned I'm on the palliative and home health side, but I'm also on the hospice side. So from both ends of that, which, services are very different, but from a provider side, one of the things that we struggle with is if our patient happens to get admitted into the hospital, we struggle with the communication back. We don't always know that our patients are there. We don't get that communication. We're oftentimes having trouble getting authorizations for services, waiting for, the authorization of the community health nurse to reach out, assign it. There's a delay in that. And then sometimes just even being able to reach the PCPs gets a little difficult. But, and from the hospice side is once we get through a process, the thing that kind of comes to mind always is how long it takes. We finally get the paperwork done, the great benefits that are out there. But what happens by the time that's processed, our patient may have passed away. So we do have those struggles, but even from the patient side of things, the things that they do is, I don't know what papers, I don't know how to find them. What papers are they going to require from me? His discharge papers, his this, his that. They look at it as now, where do I start to navigate? How do I do this? So, breaking it down now a little more detail, what obstacles will I face? Patients are fearful. They're fearful to face this process and tackle this so-called giant system. It is long and it is involved, but the end always justifies the means. And it's up to us as the professionals and our work directly as a partnership. It's up to us to help them understand and to utilize the resources that we've acquired and the relationships that I've gained to help them through this. Caregivers are overwhelmed. They're tired, they're exhausted, they're stressed out. They don't want to make one more call. So what am I responsible for? Let me help them make that call. Let me dial for them while I'm in the home making a visit. Or let me give you the number direct to my contact who I know is going to walk you through this and you're not going to be tossed around the system. And, one of the other things I always try to remind people is when somebody is in distress and they're overwhelmed, and of course, if they're dealing with end of life, if they're dealing with somebody being on service, we're going through some kind of healthcare crisis. They're not thinking logically. Reality's out the door. There is none of that. So again, it's our duty to educate and to advocate and walk them through this. More than 90% of community hospitals and physician offices don't even require the question to ask if a patient has served, if they're a veteran. So, I plead with people all the time, ask the question. Advocate. Incorporate this question into your assessment, into your evaluations. It's not more than 20 seconds to ask that question. And you know what? It should be done by every discipline. It's not just the social worker. It's not just the nurse. Every one of our disciplines, anyone who has a touching hand with a patient or a family should be asking these questions. So the other complexity that we see is what resources are there and what will he or she qualify for. There's a complexity of care here because there's so many different levels. Community health providers, as myself, don't always understand. We don't always inquire or evaluate what that veteran's medical condition might be or what it's attributed to in their service. There are things called presumptive conditions that I have learned, and these things vary by what time era they serve, where, what war were they associated with, because different diagnostics are associated with very specific war areas. Thinking about were they in Camp Lejeune, I know Dr. Bukowski just mentioned a bunch of those things too. Very different diagnostics that we see for different ages, different times, different veterans. So again, we need to educate and advocate. It's a very much recurring theme here. But the one thing that I have learned very, and I advocate for all the time too in my work with the VA here is, a person who is a veteran and is already connected has not only all their veteran rights, but they also got their civilian benefits. And they got to use the best of both worlds. 19 million veterans, 9 million are enrolled in VA healthcare. 47% of enrolled veterans are over the age of 65. 70% of veterans receive additional healthcare from non-VA sources. And the vast majority of our veterans that are projected to expire this year will do so outside of a VA facility. I know that was mentioned earlier today too. And the majority of them will be receiving home hospice. So we've got to look at the best of all worlds and what we can help them receive in putting these things together. So kind of, in summary and in conclusion here, it aligns with the national efforts. The VA does see that trauma-informed education and the screening is improving within our community agencies. 63% of staff trained to screen for the PTSD, moral injury, and suicide ideation. And 70% veterans routinely are screened for PTSD, moral injury, and suicide ideation. And the work will continue from, me as a provider and all of my colleagues out there together with VA, with Dr. B and Deb over here. We all will advocate for our veterans and we'll help them to get signed up for benefits. We're going to ask new patients, have you served? We're going to create consistent pathways for referrals and continue the relationships that we have established. They're just so incredibly helpful. We want to partner and educate on veteran specific needs. They help us, we help them with the benefits, conditions, what are our patients facing, and leverage resources with specialized agencies and promote peaceful transitions and continuity of care for all of our veterans. And with that, I just want to say thank you. And I'll take it back to, I don't know who gets it back. I'm going to bring Deb back here.
Hey, Deborah, just wanted to check in and make sure there was nothing else left before we go over some of those resources.
We've completed our work. Thank you.
Wonderful, of course. Thank you. Okay, so I know we have about 10 minutes. I am going to just super quickly share my screen. Here we go. And here, many of you are familiar with the We Honor Veterans homepage. So I just want to quickly, I know Em was really kind and was entering the link to the resource page throughout the webinar. I just want to make sure that everyone knows where this is at. So you go to our homepage under Partners, Hospice Veteran Partnership. So you're just going to click on this page. Aside from the toolkits, the Hospice Veteran Partnership roster, we have now updated and added all of these building community connections resources. Again, we are extremely happy and grateful to folks for sharing these. There's quite a number. Poke around. Many of you are familiar with the VA fact sheet for hospice partners. Just wanted to give a reminder for that. And then sort of on the flip side is the community hospice needs assessment that is given by VA to their partners in the community. I wanted to give a huge shout out, aside from the folks that were kind enough to be with us today, to a couple of other participants from the VA that shared some resources, NorCal and Indiana. I'm just going to quickly show you this. This is probably one of the most thorough packets I have ever seen. There is anything and everything that you could possibly need in here. I'm just going to scroll down really quickly. Again, there's a ton of information, a lot of partner resources, referral examples, how to refer, an FAQ page for social workers, pretty much anything and everything that you could possibly think out. So again, here's that resource packet. And we did pull out a couple of items and just turn them into shorter resources so that you can access those as well. So again, how to access VA telemental health care and FAQs for hospice social workers. Again, there are a couple of other FAQs that folks were kind enough to share with us. The presumptive disability benefits FAQ, and another extremely thorough palliative handbook. I really cannot stress enough how it is worth it to take the time, have a look through these resources, and implement them into your programs if you haven't done so already. I did also just want to give a quick reminder about the PACT Act. We have a PACT Act resource page. We are keeping it as up to date on information as possible. Anything that comes down the pipeline, we add to this. There are a ton of resources up there already. Some phone numbers, a couple of webinars, and different informational things to access. And we are currently working on the best way possible of putting together a webinar or another overview that we can provide community, our community partners with what they need to know about PACT Act and serving their veteran patients. So just wanted to quickly go over those. So without further ado, I know we did have a couple of questions. I did my best to capture them, but Em, please jump in if I am missing any. I know that someone asked if the homemaker program could be explained. They said, I'm aware of home health aid, but for personal care only. And are these services available to rural vets on hospice? This particular partner mentioned that they are over 3 hours from their VA in Saginaw, and they were wondering specifically about the homemaker program and the placement program, as there's no VA hospice unit near them, as far as they know.
I can speak a little bit to that. The Homemaker Home Health Aid Program is for veterans who need assistance with ADLs and IADLs, and that's how they prioritize who gets those services. And they're not available in all areas. So it just depends wherever the VA can contract with area agencies. So even here in California, there's certain geographical areas where that isn't available. And then the other question, about the inpatient hospice. Yeah, it just depends on your area. Some VAs have an inpatient hospice unit, other VAs don't. So it just depends. And that's why we have our VA contracted nursing homes, so we can place veterans in skilled nursing facilities that aren't near our VA hospice units.
Thank you. And I also just want to remind and stress to folks, if you have any questions or are ever having difficulties, you don't know who to call, or you're having any troubles contacting someone, reach out to us. That's what we're here for. So reach out to the veterans inbox, myself or Em, and we will get you connected with anyone that you need to, typically within 24 to 48 hours. So just please keep that in mind as well. Always use us as a resource. Okay, one other question, is the telemental health for community veterans and hospice in place at all VAs, or do we have to initiate the conversation with our VAs to start it?
So every VA has mental health services. So it's just a general mental health consult. And then with more context, they will assign it to the mental health provider most appropriate to address the end of life care needs and the trauma, the past trauma too. And maybe they've already connected with a certain VA mental health provider. So that should be a part of every VA's care, is the mental health component.
Okay, next question. What specific screening tools do you use or are available for PTSD and moral injury?
Someone else can speak up too. I don't want to dominate the Q&A. And maybe I found that some of our hospice agencies also have their own screening tools for PTSD and past trauma. Our team relies very heavily on the mental health team, so we're often asking them and relying on them for that specialized screening and care.
Yeah, I want to remind folks, we do have a screening guide that was created in partnership with NHPCO's Trauma Informed Care Work Group that is available on the We Honor Veterans page. We can type that link in the chat box in just a second as well. Sorry, Debbie, I didn't mean to cut you off if you were about to mention something.
No, this is Dr. Blakowski. No, no, we were about to say the same thing. I think each facility has their own guide and their own criteria for identifying these patients. It's actually a very good question. It's because it's so difficult to determine what if the patient has PTSD or a moral injury, but it's the most important thing is to reach out to your own individual VA facility if you have any questions or concerns. I think the problem that we've encountered is that one of the things you don't want to do is to push a patient who has problems with PTSD or moral injury over the edge. So sometimes it just takes a lot of gentle hand holding, but if you have any questions, just reach out to your closest VA facility.
Yeah, thank you. I did also want to add that a group of VA subject matter experts did create an incredible training video on PTSD and thank you. You included the link in the chat box as well. And that is available for free, open for anyone to access on the We Honor Veterans website.
I think that is all the questions, Catherine. I know a couple of them were answered in the chat box already by some folks, which is great.
Thank you. Okay, well, we're right at time. Yes, if there are no other questions, and if something happens to pop into your mind at a later time, or you come back and give us another watch and want some clarification, please reach out to us. Again, we're always here and happy to answer anything. And if we don't have the answers, we know who does, so we can always connect you. I want to thank everyone again, all of our speakers for their time, not only today for sharing what they've learned, but for the time that they spent in this initiative and all of the care that they are giving to these community partnerships. I really don't think that I can say how incredibly valuable that is. So really, really thank you all. And again, this recording and the slides will be posted likely tomorrow, Monday at the latest, but we're here if anything else comes up. And thank you again to everyone.